Okay, so let me start out by welcoming everyone and thanking everyone for spending some time with us. We want to have a very kind of informal Q&A session with some people that I watch a lot on social media. So why don't we go around and introduce ourselves? There's three of us, and let me use the format. I'll start. I'm Dr. Choll Kim. I'm in private practice in San Diego. I specialize in minimally invasive spine surgery. I take care of mostly adults who have problems in the disc, and probably the most common surgery that I do is the laser endoscopic surgery. And then just to say kind of one thing about myself personally, let's see, I love playing golf. I love snowboarding and kickboxing. I was also I'm a Scorpio, born on the year of the dragon on Friday the 13th. So yeah, something bad's going to happen to me, but I've been making it for the last 59 years, so I'm hanging in there. So how about Dr. Grunch, the famous Dr. Grunch, lady spine doc? You go next.
I am Betsy Grunch. I am a general practice neurosurgeon out of Atlanta in a town called Gainesville. I've been in practice for 10 years. I specialize in spine. I'm a fellowship trained in spine from Duke. And the most common procedure I do in my practice is disc replacement and minimally invasive surgery, but I do everything spine for the most part. Interesting thing about me is I practice in the hospital in which I was born at.
Wow.
Well, it's such a pleasure to be with such distinguished panel here. I am Hamid Abbasi. I'm a neurosurgeon. I practice minimal invasive spine surgery. And most of my surgeries are minimal invasive lumbar spine procedures. And the fun thing about me is I take a piece out of a radio and repair a refrigerator with it.
Okay, I can't even begin to fathom what that's all about. So we have to hear about that more. Okay, so I specifically chose Dr. Abbasi and Dr. Grunch because I see a lot of their social media content, and they have a bunch of content that has lots of views, and you can tell they have lots of insight on many different topics. So at some point, we want to answer some really specific questions about patients, but I'd like to start out by asking some very general questions. Let me start out by asking Dr. Abbasi the following. Dr. Abbasi, is it better to be loved or feared?
I hope this is not a controversial question, because I think it's always better to be loved than feared. Even if you're the most egocentric person in the whole planet and people love you, they still love you when you don't look over their shoulders. So I stay with that.
That's your story. You're sticking to it. Okay. We're going to ask your staff about that later, and we'll get back to the real answer of what really happens in the background. But yes, I agree with you. Let me ask Dr. Grunch the next question. Kind of general. What's the weirdest talent, skill, or trait that you have that not that many people know about?
Well, I keep my life very public, so people probably know everything about me. But I think, a talent that I have is I can wake surf. And so, yeah, and I can wake surf with my kids on the board. And that's something fun that we like to do together.
Oh,
I also wanted to point out, I think that's
a good skill.
Yeah, it's fun. I want to point out too, I think we've gotten some questions in the chat that people are like trying to talk. So we can't hear you guys speak. It's just going to be limited to the speaker speaking. But if you have questions, just type it in the chat box there. So.
All righty. I'm going to start asking you a little bit more specific questions now. And we got a bunch. So the first thing is we get a lot of questions about this basic question. Are there pillows or special beds that people should look into if they have neck and back pain issues? So why don't we start with Dr. Grunch? What do you think about that question?
Yes, I think as spine doctors and spine specialists, we get this question a lot. And I personally have kind of like took interest into investigating this. And I think it's really pretty general response to that question is that I think for the most part, whatever position you sleep in, it's important to keep your spine in a neutral position, meaning Pillows that are like kind of fluffy, your head might sag down. But as long as your spine is straight, like if you're a side sleeper, I recommended like a supportive pillow. The Pillow Cube is one that I recommend, a specific product, but there are many pillows out on the market, and especially like something between your knees if you're a side sleeper to keep your spine in alignment. If you're a back sleeper, just keeping your knees bent. And then if you're a stomach sleeper, it's not a good idea to be a stomach sleeper. That's just not a good position for the spine. But in mattresses, I typically recommend a pretty firm mattress just to kind of for the same reasons that I mentioned. So,
yeah.
What do you think, Dr. Abbasi?
Well, before I answer that, Betsy, my congratulations and a fantastic job to put your life out there. I think generally surgeons are very private people, and by you putting your life out there, you give a real taste of who we are to the greater community. Regarding the beds and the pillows and so on, our body naturally reposition us in the sleep numerous times, and spine is the most complex mechanical device, mechanical things. It readjusts itself thousands of times every second. All these hundreds and thousands of muscle that we have in our body, they readjust themselves. Certainly, everybody has a different kind of comfort level, but generally, what's comfortable is good. What's not comfortable and cause pain is bad. And firmer mattress has been, I think, in many studies proven that your body has to adjust less, like those water beds from 1980s. They were horrible.
yeah.
Your body has to work all night long.
Yep.
So, that firmer mattresses, more neutral position certainly contribute to better spine health.
What do you think about sleep in and of itself? Because one of the things that I notice is that at least Americans have a serious sleeping disorder as a general population.
Mm-hmm.
We don't sleep normally. We have too much stimuli right before we go to bed. We drink way too many stimulants, et cetera, et cetera. So
Yeah, no,
sleep in and of itself has an important part in spine health.
Yeah, of course. I mean, and for the brain health too. I mean, and talking about neuro stuff. I mean, the lymphatic system. I'm really fascinated about like how our brain like processes during sleep and cleans itself. And so there's been some newer research in the past few years on the lymphatic system, which is our body's natural way of cleansing our brain. And there's been multiple studies that also prove that if you don't get good deep sleep, that you are at higher risk of dementia and those kinds of things because your body can't cleanse the inflammation and the toxins from the brain. So sleep is so important, and deep sleep is so important. So the things that we mentioned, like, repositioning yourself if you're uncomfortable during the night, waking up multiple times to reposition yourself, that can affect your deep sleep and therefore affect your cognitive, not only your spine health, but your cognitive rest as well. So sleep is so important. And like the things you mentioned, I've done a few videos on ways to prevent insomnia and like sleep hygiene and really making a good sleep schedule that's a more regimented, like consistent on a daily basis is very important.
Yep.
Yeah.
It's not just the bed and being comfortable in bed. It's actually being able to get through all the sleep cycles, which is really complicated, and getting to that deep sleep when our brain does a bunch of stuff to kind of repair ourselves.
Now, as a neurosurgeon who is trained before they had rules regarding how many hours you can work, in my residency, I used to work 120 hours a week. So I can tell you all the consequences of sleep deprivation and this especially sleep cycle, the stage 4 sleep, the deep sleep. If you truly are able to deprive somebody of stage 4 sleep, they live only 4 days.
Yeah.
So that tells you how important that sleep cycle is for us, for our memory, for our brain, for our spine is certainly part of it. But a good quality sleep is a big part of being healthy.
So, Betsy, I have back pain. And I have trouble getting to sleep. I also don't exercise and have a very stressful job. And I'm supposed to go to physical therapy, and I'm supposed to eat healthy and not drink so much caffeine, but I just can't help myself. Of all the things that you kind of see in a patient, what is, you think, the lowest hanging fruit that you can tell somebody like me, like, start with just this. Can you do something like that? Or
Yeah, I mean, I think for the back, minimizing stress and getting good sleep are probably the most important things that you can do for your spine health and overall health, because they do go hand in hand. So,
what do you think, Hamid?
Dr. Choll, with what you described, you're a mess.
I know.
We need to start the whole rehab on you. So
that was just an avatar I created. It has nothing to do with me, I swear.
I know. Now, now that the lowest hanging fruit of every person is a different one. Now, if you are at $1 million in debt, I can't tell you all day long, work less.
Yep.
And if you are in pain, I can't tell you all day long, sleep more. You can. But I think
I find myself hanging my hat on exercise. So when everybody asks me that, I say, okay, it's complicated. It's not just one thing. It's a multitude of things that all need to come together. But if there's one thing you're going to do, is you got to start exercising more.
And what you can, it doesn't.
And I don't get a very good response from most people.
Yeah.
They really think I'm putting the burden back on them instead of on me to kind of get them better. But I honestly think that if that's one thing that they could do, is develop a really regular and consistent exercise program that will decrease stress, that will make them sleepy at night and get into deep sleep better.
Yeah.
I say this only because that's just my kind of my guess. It's not because I'm a sleep expert. What do you guys think?
Betsy, take it on this.
I mean, say that again.
You think that's an oversimplified advice?
Yeah, I mean, it's just so complicated, but I think the most important thing is just a good regimen and a good consistent schedule. And, like I tell people, if you sleep 6 hours consistently, like 12 to 6, that's more important than like sleeping like 6 hours, but kind of like spread out during the day at all different times, different days of the week. Because your brain is more, we all do best on schedules, and I think that includes that. So
yeah, discipline is important, but as well exercise, I think, as you mentioned, Dr. Kim, is extremely important, and it doesn't have to be so half marathon and so on. It's just walking your dog every day 10-15 minutes. That's a good start. I think start with things that you really can fit into your life and take it from there.
Yep. Okay, so let's talk about the patient that comes with back pain and some radiculopathy, or even something called neurogenic claudication. That's when the nerves are just crowded and they don't get enough blood supply. And as you stand and walk, your legs become either kind of achy or numb and tingly or painful or wobbly or some combination thereof. You've tried physical therapy, you've tried going on a low inflammatory diet and getting good sleep, and you're still having symptoms. And MRI shows that you have some abnormalities. So I would say that most of my patients now at this point will try some type of epidural steroid injection. So one of the questions that we have is, let's start out with, what do you think about epidural steroid injections and how often you utilize it in your practice? And the question that we had asked is, does it matter what steroid you use? And then I also personally want to ask, do you use anesthetic within the injectate for diagnostic purposes? So let me just start out with Dr. Abbasi. A patient that I just described to you, what would be your next step normally?
Well, the next step for me would be examining the patient, literally crystallizing the clinical exam. Now, unfortunately, this is the last 20 years or even maybe longer. Some spine surgeons, they look at the film, not having even seen the patient, they already have a plan for the next 3 years treatment for the patient. I don't do that. I examine the patient and I understand what the expectation of the patient is. And then I develop a plan that if sort of in the direction of what patient's expectation is. Now, coming back to steroid, we have been using steroid longer than any medication, and we know it works, but it's not just a medication without side effect or complication itself. Now, we know in certain situations, for certain medical conditions, steroid can be extremely helpful. We have highest level of evidence that they work. But just in the last 10 years, we have understand, especially in neurosurgery in our societies, that risk versus benefit might not be the best for everybody. So it's
am I hearing you correctly? You tend to use epidural steroid injections less more recently?
No, not for mostly if I'm talking about trauma in our societies, they say, they for especially elderly people with diabetes and so on. No, I still believe and use that a lot. And your question was as well, what kind of steroid I use? Most of studies, as we know, they say not a huge difference, but I like to use particulate steroid that release their steroid over a period of time rather than something like you put it in and within few hours it's just washed out of your system. Betsy, what do you think?
Okay, Betsy, I'm your brother whom you love and adore, and you see at every holiday and birthday event. I don't know if you remember what the whole avatar is, but I have back pain with some radiculopathy, kind of neurogenic claudication radiculopathy. And I'm kind of limping along and I'm not enjoying golf anymore. And by the end of the workday, I'm a total terror and cranky. I'm just making all this up, okay?
Yeah.
What would you do next? Would you do an epidural steroid injection next, or would you start thinking about surgery?
I mean, I think it depends on the pathology, obviously. Usually lumbar stenosis with claudication is something, that problem isn't going to go away. Like, in other words, the stenosis or the narrowing or the bone spurs or the thickened ligament isn't necessarily going to go away and can get worse over time. If it's a disc herniation, those may resolve. And so I think it depends on the problem. But if we're talking about someone with just bony overgrowth and just general stenosis with bone spurs, I talk about, all options if it's severe. I mean, ultimately, and they're symptomatic, the likelihood of a lumbar epidural steroid injection curing them is low. So if they have mild to moderate, I think it's definitely reasonable. So I go through those options and we talk about, surgery, if that's decompression surgery or whatever. And then, I talk to them about what their time frame is for surgery. If they're like, I'm a farmer and it's the summer and my whole crops are dependent on me, but I can't do surgery until the winter, then let's get you a steroid injection. Maybe we can get you through the season and get you ready for surgery later. So all those kind of play a part into it. And I think steroid injections aren't the end-all cure, but I do think in some patients it can cure them. Depends on the pathology, but it's always
overall, would you agree that they're pretty safe?
Overall, very safe. I think I always find surprising how many patients are scared of getting an epidural but are not scared of surgery.
That's exactly what I say too. If you're scared of an epidural steroid injection, you should be petrified of surgery. And then I always end with, if I were you, this is what I would do. I always ask myself that question. And the answer seems to pop out. If it doesn't pop out, I'm just like, I got to think about this in my subconscious. But I do a lot of epidurals. I want to get to this question about PRP injections and stem cells, because that's really, a lot of my patients are doing that. But I want to ask you another question. I specifically ask my pain doctors, and I have to go through great pains to make this happen, to include an anesthetic in the injectate. Together, like a 50-50 mixture of, it used to be 0.25%, but it's now 0.5% marking with the one-to-one mixture of the crystalloid steroid. And I have the patient really monitor their symptoms and try to provoke their symptoms during the first 3-4 hours, because that gives me a lot of diagnostic information. So if I do a transforaminal targeted injection on the side that I'm worried about, at the level that I'm worried about, and they get temporarily better, when I do surgery on those patients, their likelihood of getting better is like 80 to 90% versus 50-50 if they have a negative diagnostic response. So in San Diego, virtually no one does anesthetic injections. What are your experiences with that? And do you have any concerns about including the anesthetic in the injectate?
I don't go. You can, Hamid, you can answer that. Yeah.
Yeah. Well, no, you go ahead. Ladies first.
I don't think the anesthetic, for my practice, I mean, most of the pain physicians that do the epidural injections include the anesthetic, and just for symptomatic relief right off the bat, and it can help from a diagnostic standpoint. I think it's important in like SI injections, particularly when you're dealing with sacroiliac disease, like I need to know right after you get the injection if it helped or if it didn't. And if it's just a steroid without the local anesthetic, you may not be able to tell that necessarily. So it's helpful from a diagnostic standpoint, which we use so many injections to help us make surgical decisions. So.
No, and absolutely. And as we know, steroids, they go inside of your nucleus of your cells, they modify the expression of the genes and enzymes, and that will take days before it works. So you don't get the effect immediately. Now, I always use local anesthetic, and I send it my patient to people who use local anesthetic. I know that in many areas of the country, people don't do that, because if you are wrong and put local anesthetic and you put the steroid even in the wrong place, the effect is not super bad. But if you put local anesthetic like inside of the spinal canal, where the nerves are, inside of the dura, then patient will quit walking. And if you are higher up, the consequences can be severe. And I can imagine in California that most of people who do that, they don't want to get that route. But the reason I always use, because number one, I send my patient to people who are extremely experienced. The chance of putting the local anesthetic in the wrong place is extremely low. Number two, the psychological effect is immense. They walk out of that room with the pain gone. And number three, as Betsy said, it is diagnostically, it's extremely important, especially for certain.
I'm glad you said that, because I find it, at least in my practice area, very uncommon, and I have to convince the pain specialist to do it. They're very worried about this potential palsy or anesthetic effect. It should be temporary, but it just hardly ever happens in that dosage. Okay, let's quickly talk about PRP injections, because I've noticed a lot more of my patients are getting PRP injections for herniated discs, for degenerated discs, symptomatic annular tears. What's your experience with that? Hamid, why don't you go first?
Now, just to be honest, I don't do it, and I don't send my patient for it, because based on the information that we have so far, the results are not extraordinary. I'm not saying there is no results, and there's so many things. I go back and forth like ping pong or boomerang. I go back and forth, things I didn't used to do. Now they found that it has an effect, and I start doing that. And but based on the current information that I have available to me, it is not the primary kind of way I treat the patient. But, you know, I always talk to the patient, you know, these are other things that you can consider. That's PRP, plasma-rich protein, where they take your blood, enrich it and give it back to you, or even stem cell, or even amniotic fluid, that some studies show it has an effect, but some other studies shows it doesn't have an effect. But I'm always in the process of learning more about it.
What do you think, Dr. Grunch?
I mean, I'm really intrigued, but I just, you know, there's not a lot of long-term data on it. I do talk about it a lot with my patients, particularly I've had this run of really, really young patients with symptomatic annular tears or degenerative disc disease for a while. Like this month alone, I think I've seen 3 teenagers and several 20-year-olds with really debilitating back pain that's been there for a while, like over, you know, years, and just a single degenerative disc. And, you know, I mean, of course, disc replacement's an option, but in my mind, putting anybody 20 or younger through disc replacement seems almost, I don't know, it doesn't seem quite right. So I always try to encourage alternative treatments, including PRP stem cells, just to see if they get any relief, because there's really not a downside. What is your experience? I think
because we're in Southern California, we tend to be pursuing these alternative treatments a lot more frequently, it seems like. So I have a lot of patients that seek out PRP treatments, a lot of patients that have had PRP treatments by the time they get to me. The data in like the orthopedic literature for tendons, especially patellar tendonitis, Achilles tendonitis, etc., they've been clinically effective, and they work well as like a biologic modifier of healing. So the idea is the same thing for the disc, but I don't think that the data is out there. But I've not seen any negative effects, and I've seen some positive effects, but I think the jury's still out on whether or not it's truly efficacious. But the safety is there, and it seems very biologic. So I'm pretty excited about it. But you know, I kind of just watch carefully the first few patients to see how they do. And it's been 50-50 so far, which is not bad because it's just an injection. Which brings us to the next question. Disc replacements versus fusions. And there's two questions to this. The first question is, it seems like we do a lot of disc replacements in the cervical spine, but not that many in the lumbar spine. So why do you think that is? Betsy, do you want to go first? Do you have a reason why you might like one or the other, or just in general, we tend to do more of one than the other?
Yeah, I mean, I'm a big proponent of motion preservation, and in any patient in my practice in which I can restore or not fuse them, I love that. And that's in the lumbar spine as well as the cervical spine. I think lumbar spine is not done as much as cervical for a multitude of reasons. One, it's not well approved by insurance companies, and especially multi-levels. So it's very rare that someone comes in with single level pathology. And two, I mean, it's even sometimes very hard to get approved as a single level. And I think for the biggest barrier, I think, is access surgeons. Not a lot of surgeons have a good access surgeon to get them to the anterior lumbar spine. And unfortunately, I hate to say this, but I do think it comes down to, I mean, it's a highly technical procedure. It's so much more difficult than an anterior fusion, and it's less money reimbursement wise for the surgeon. So you're doing a lot more work, a lot more risk, and less reimbursement, and a higher likelihood of something potentially going complicated, and they're hard to revise. So I really think that all that kind of weighs in to that. So I love lumbar disc replacements. I'm one of the only few in the state of Georgia that does them, which is surprising. So I get a lot of patients that come to me just for lumbar disc replacement. I think that's probably my most common reason why people see me from social media, is because of lumbar disc replacement.
I did not realize that. And it's funny, every lumbar disc replacement surgeon that I know and trust, you can tell they do it well, and they love that surgery. So I want to start doing that, but I have not done a lumbar disc replacement surgery since the trials. I do a lot of cervicals, but I hardly ever do lumbars.
Yeah.
But it's a technically it's very difficult to do a good lumbar disc. It has to be huge.
Yeah.
It has to be put in perfectly. And you have to go through a lot of really scary anatomy from the front.
Yeah, and the patient's size, you have to have a patient that's a normal body weight. And unfortunately, people with lumbar degenerative disc disease are, I mean, for the majority, are overweight individuals, and putting that going anterior through an overweight patient, plus the strains that you have, plus difficulty in doing the procedure, vasculature, blah, 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 just makes it a risky surgery. So.
And in lumbar spine, you never want to go back.
No, never. I've done it. I did a revision. I had a lady come to me from social media with a misplaced lumbar disc, and it was one of the most technically challenging surgeries I've done. It went very well, but
anybody
I don't. Ooh, it was not fun. It was 5-1. I don't think 4-5 you could really do safely. So
no. Anybody who has ever done an ALIF revision knows when you go back there, what you have to fight to just get where you need to go.
Right.
Now, I'm a big fan of technology. If there is a gadget, I'm usually the first to adopt, except in medicine, in my profession. And 6 months ago, I was in Germany, and you may know that many of these artificial discs come from Germany. I'm a German citizen. I know I don't look like German, and I trained in Germany. I talked to one of the fathers of the artificial discs in the lumbar spine. And that interview is online. People can look it up. He explained to me why he quit doing that in the lumbar spine. And many of that is the technical difficulty, ever going back there, and so on and so forth. But I think we should just have a conversation just about artificial disc, the future of it. There are a lot of biomechanical things. You just both mentioned that. If you are wrong even a little, that aggravates the effect on the facets, the biomechanic, and so on and so forth. The center of the natural disc is not fixed. It moves based on the position.
Because it's a cushion. It is not an articulating joint like the knee or the elbow or the hip. It's
amazing.
It's a shock absorbing.
The biomechanic of it is amazing. It's extremely complex. And I think we will be there. But, this is a conversation that can go on and on and on, but I'm going to stop here.
All righty. So I think we're all on the same page. If you can put in that lumbar disc replacement device well in the appropriate patient, it's a great procedure. The problem is that, and this is a big problem in general in terms of medicine. I don't know that we want to go into this and spend all day into how insurance companies affect our decision-making, but it is a technically difficult procedure to do where we get paid way less than the easier counterpart, which is the fusion procedure. So just think about how that would affect behavior. I mean, humans are humans, you can't help but tip the scales in one direction or in another when you have that situation. So I would say that that's probably the main reason why we do a lot more cervical disc than lumbar discs.
And
because the difference in payment is not as bad, and the difficulty is not as profound as in the lumbar spine.
And as well, I think you have to be an artist to choose the right patient for it.
Yep. So now everyone knows who to send their lumbar disc replacement patients to. Those two.
No,
I think we should answer. I don't think we've answered
really
this, but I think this is a great question. We should describe the differences between a neurosurgeon that does spine and an orthopedic spine specialist, because I think that's very confusing to people. So Dr. Kim, you are ortho.
Yep. I get asked that question a lot.
Yeah, so answer.
Well, I would say that the most important thing is that if you're doing spine surgery on somebody, you predominantly are a spine surgeon because of the simple fact that this field of spine surgery is now so complicated that it requires pretty much your full attention to remain an expert. And the simple analogy would be like Michael Jordan playing basketball versus baseball. I mean, he is Michael Jordan in basketball, but in baseball, he's just kind of mediocre. So you decide, do you want to be mediocre or do you want to be a Michael Jordan in your field? Because if you want to be a Michael Jordan, you just have to be a spine surgeon. And I would say it goes even further now because there's so many of us that if you needed a lumbar disc replacement device, I would immediately send you to somebody like Dr. Abbasi or Dr. Grunch, because it's like sports. You need to not only be in your specialty, but you have to practice. You have to play, you have to have experience, because nothing kind of can replace game time, the amount of time that you play in the game. So I would say that it doesn't matter if you're an orthopedic spine surgeon or a neurosurgeon, when you pick a surgeon to do your surgery or to take care of you for a particular problem, you want to make sure that that surgeon is really familiar with that problem and that procedure and is taking care of lots of patients with lots of experience, especially if it's kind of a unique problem. And most patients with spine problems are unique. So that's why we get so many different answers. But that's my long-winded answer to your relatively short question. Sorry.
Now, Betsy, I'm a neurosurgeon like you. But the most of the high-level thing I learned in the spine was from orthopedic surgeon. Not that my training with neurosurgeon wasn't good enough. It was spectacular. But considering that this orthopedic surgeon, they're just so much better with chisel and hammer and so on. And you and I in the OR, if we have a chisel and hammer in our hands, we get scared already holding a chisel and hammer in our hand, because we learn to brush that facet layer by layer, spending 15 minutes to take the facet off. I watched my orthopedic colleague, his name is, by the way, Dr. Kim as well.
I know exactly who you're talking about, Sonny Kim. He's great.
So he take a chisel, a hammer, tap, tap. The facetectomy is done in 15 seconds. So I think I benefit so much working with him, learning his skill, because he comes with a different tool skills with tool sets. And he watched me doing one of my spinal cord tumors. And he was amazed that I'm not afraid of opening the dura. Big deal. I open it up, put the tags on, open up, I look at the cauda, I work around the thing and so on. So I think that the power of combining people who come from different direction and become spine surgeon, I know this rivalry and friendly competition, who is better, spine surgeon, neurosurgeon, or orthopedic and so on. But I think once you have been in the field for a few years, it doesn't matter which direction you come from. Having said that, you just have to have the tools. You have to, if you're a neurosurgeon who has seen complex spine, you're as bad as if you're an orthopedic surgeon who has done only 3 months of rotation on the spine.
Yeah, I think it ultimately depends on the training of the individual. So in general, orthopedic residency, you do, a 6-month, 8-month rotation on spine, and then you do a 1-year fellowship. Neurosurgery, it really depends on the program. For me, I came from a very spine heavy program, and I did spine for 6 years and then did a 1-year fellowship. So I had a vast spine exposure with ortho neuro going into practice, whereas some of my orthopedic colleagues maybe not so much. But so to your point, once you get out and practice and you do a lot, it's really it kind of equivalates up. And typically, general speaking, orthopedics are good with instrumentations, mallets. I mean, they're doing hip replacements, knee replacements, working with hammers. Neurosurgeons are working delicate suctions with brains and opening the dura. And so, I think if you had, a spinal cord tumor that needed to go inside of the cord and do something very delicate, probably you're going to find more neurosurgeons that feel comfortable doing something like that. And, more deformity surgeons. I am a neurosurgeon. I do deformity because I was trained in my program, but you'll find in general more orthopedists do deformity work. So I think ultimately, if you're looking for a spine surgeon, which I think is the question that these folks are trying to get at, who's best, I don't think the specialty matters. I think the surgeon matters and doing your research on the surgeon. So
yeah, Betsy,
and the procedure that you need, so
Exactly.
Betsy, I have a question for you. As neurosurgeon, we are brain surgeon, but I found spine pathologies and procedure are to be more complex than just do a craniotomy and taking a tumor out. This is what I found. What's your take on that?
I agree. I think spine is so difficult from a diagnostic standpoint because the spine is so complex and the different pathologies that can affect the patient's presentation. And it's challenging. I mean, you got a tumor, you take it out. You got a spine problem, it can be from a million things.
Yep.
All righty, let's talk about that. What is the most challenging patient that you have in the office? Start with you, Dr. Abbasi.
Well, I can tell you a long list because this patient come from entire United States to me. I just did a surgery on a patient with a BMI of 64.5. These are tremendously difficult cases, and nobody ever doubted that this patient needed surgery, but trying to do surgery, and the nicest person, I put a video out there where she's singing Amazing Grace. She came all the way from North Carolina to us in a small place for us to do the surgery. The most challenging patient is a patient that has a situation that you're walking a narrow path. Now, every surgery with us is a risk versus benefit, right? Now, in some patients, you have so many different choices. You have so many capacities, so many resources to use. In certain situations, you have very few resources. You have a very narrow path to walk. You have such a low threshold for complication. And then the most difficult...
What kind of patient is that, though? Well, is it the very elderly patient with osteoporosis and an L4-5 spondy with severe stenosis? Or is it the 35 or 40-year-old with chronic low back pain that is just really affecting their function and quality of life?
In my practice, that is the elderly who is, the choices are, you have to live with the pain or you have to accept a high rate of complication. Then I have to come up with ways to reduce the complication, and I have to stay realistic. And because the alternative to that I have seen, just last week we treated a patient who had the consequences of not being able to be taken care of by anybody else. He is the nicest person. He
has no support at home, you mean?
Yeah, and because he couldn't take care of himself, sometimes we tell our patient, you have to live with it because surgery is not reasonable for you. The consequences of living with it is tremendous for the patient. And my challenge is to balance risk versus benefit. Say, how much risk am I willing to take for you to offer you the surgery. That is the most challenging part, making the decision. Once I make a decision to do the surgery, the surgical part is actually more straightforward. Trying to
What about, let me ask Betsy, like what about the specific issue of somebody that is elderly with severe osteoporosis and they have a spondy that we would normally fuse with screws and rods and cages? How do you deal with somebody like that?
Yeah, I think those are the most challenging cases, because if they're coming to see us, they're looking for answers for their pain, and to tell them they're not a candidate is hard. I look into their osteoporosis. How bad is their T-score? Are they like borderline, or is it like minus 4.8 where there is nothing in God's green earth that can make their bones strong? If they're borderline, I mean, I'll usually do some Tymlos or Forteo or one of those bone building drugs, and then discuss the risk benefits of fusion. And the longer I've been out in practice, and gain more experience and outcomes and what patients do well with what procedure, I think that neuromodulation really is a great option for a lot of people. So spinal cord stimulators.
Oh, wow.
And I really use that a lot in my scoliosis, osteoporosis patients. And you know, I mean, it's not a slam dunk win for every single patient, but such a good option for a lot of people that's not as invasive. And when they do well, it's such a great salvage for their pain.
And
That's a
at the
great
end of the
idea.
day, we want to treat their symptoms.
Yeah.
Sometimes we just need to make them comfortable enough, and and at least that's a conversation I have with the patient. What are you expecting from this surgery, and what the lowest invasiveness that we can achieve those goals?
Yeah, I would say that I have a much more pragmatic strategy, because by using all the MIS techniques and bone cement and just being extra careful, I've gotten away with it. My hardest patient is the younger patient that has, you know, like a musculoskeletal low back pain. They're not bad enough to warrant a big operation like a fusion or a disc replacement. And they don't have something simple like a symptomatic annular tear that I can just go in and do an endoscopic discectomy, or somebody that have done an endoscopic discectomy, it's not enough surgery, and they're considering doing a fusion surgery right in the middle of a situation where they're in the middle of a really busy career. They can't take 6 months off because they're going to miss their promotions. Just imagine, like, when we're building up our practice, to have to take 6 months off, it would be devastating. So I have a sea of patients like that I took a lot of my practice, actually, since I take care of like a group of people that have disc problems. And it's mostly trying to be like, I don't know, like a life coach, which I'm not very good at. So I have a lot of videos, I have a lot of handouts that I give to people, but it has been an uphill battle. How do you deal with that kind of patient? Do you have like a whole separate program where you have like psychological coaches and training coaches, or do you try to just tell them to scare them straight with a threat of surgery? How do you guys deal with that? Okay, I feel a lot better about myself.
Yeah.
I mean, I think those young, are you talking like to the situation as a young patient with what? I was answering a question in the Q&A, so I missed the first part of the.
Yeah, let's say it's a 45-year-old lawyer trying to become partner. He's got 3-level disc disease on MRI, and it's like you can't figure out where the pain's coming from on discogram or targeted diagnostic injections.
Yeah, those are
so you're like 2-3 level fusion versus just living with it. What are you going to do with this patient?
Yeah. So, I mean, if you really, these are patients we see every single day. Is what do we do? I mean, so I usually use diagnostic injections if it's like a leg pain, like pinched nerve type pain. We try to go based on the anatomy. I talk to them about the pros and cons. I mean, a 3-level fusion versus an endoscopic foraminotomy, those are night and day procedures. So sometimes if I really feel very, think that it's coming from something, even though the testing really hasn't confirmed it, say, hey, like, this is the risk of doing this small surgery. If it doesn't work, it's such a low risk procedure that it may or may not, may not do. And then if we end up needing to do a fusion, then we can potentially discuss that. And again, I'll go back to my soapbox on neuromodulation too. And I think even in young patients, it can be, somewhat helpful. So.
All righty, we have a question. What would you say the success rate for a fusion for an L5-S1 spondylolisthesis?
I think it depends on the technique. I think success rate for most patients that have a good surgery, that aren't osteoporotic, that don't use nicotine products, the fusion rate from a lumbar fusion is high. 5-1 is the most challenging, in my opinion. I don't know about you guys, but I think 5-1 is the most challenging level for a fusion for healing. It takes so much stress. I tell my patients it's the foundation of your spine. So we need a lot of structural support at 5-1. And if you don't have an inner body, I just think it's hard to heal from. So my typical fusion for 5-1 is anterior. If it's a spondy or a slippage where you have instability in the spine, I do an anterior and posterior fusion. And it seems very daunting for a patient to think that someone can cut you from the front and back and do all this stuff. But the bottom line is, when you have a surgery, you want it to be successful. And if it's not successful, doesn't matter what we do, it's not successful. So you want to invest yourself in getting the right surgery for the right problem.
You talked about this before, but at L5-S1 in particular, the size of the patient matters. Is there like a BMI cutoff that you use for an L5-S1 spondy?
I mean, in my practice, I loosely have a BMI cutoff for any surgery around 35. Depends on the procedure, but it's so hard. I mean, I tell patients, and talking about patients' weight is such a hard thing to not sound like you're not calling them fat. You just want them to be successful in their surgical outcomes. And I think with all these GLP-1 drugs and all the availability of help we have now in the medical field to help with weight loss is so important, because I've done, back in my earlier days in practice, fusions on patients that are, really overweight, and they don't fuse. And if they don't fuse, then they're still going to have pain. And then you've gone through all this surgical for nothing, and it's hard. So I really try to counsel patients a lot on that on the pre-op end. I don't know Hamid, what do you?
Yeah, well, all the societies now, they recommend not to do traditional surgeries on BMI above 40 for a good reason. What you just described, lots of perioperative risks, a lower chance of fusion because of the mechanical stress that we put in. But we actually published a paper just actually 5 years ago, where we compared the BMI, the effect of it, time of the surgery, complication rate, and that is a different conversation. I regularly perform this surgery on BMI of 50 because the way I do the surgery, I cause a very little damage to surrounding tissue, and I have years of follow-up on this patient. That literally I have 28,000 clinical follow-ups, not all of them on high BMI, but a good number of them on high BMI patient. That if you,
I think, Hamid, you're talking about all your techniques are very minimally invasive.
Yeah, very
minimally invasive. The BMI effect is much less. I've noticed exactly the
depending on what kind of MIS. MIS TLIF, actually, after BMI of 37, this is what we found out. We had lots of patients, 400 patients in one hospital 1 year. We found out after BMI of 37. So I applaud your BMI of 35. Very good number. Because after BMI of 37, MIS TLIF can have more complication than open TLIF, because they have to work on a deeper hole, much harder, do much harder surgery. Complication rate is actually higher. But if the way I do the surgery, I use a tube that is barely, not even half an inch, it's 10 millimeters. And then it doesn't matter if you do the surgery, you go through 2-inch or 4-inch of fat. Obviously, the mechanical consideration. This is not instead of losing weight. As Betsy, I have seen some of your videos. I applaud you for that. Doing surgery is difficult in this patient no matter what. And I don't perform this surgery on these people instead of losing weight. if everything else has failed and everybody has told the patient you have to live with it, I'll go lose 150 pounds, they go and gain 150 pounds because they cannot walk. Then they come to me, and I have a good track record that if you consider certain technical aspect of it, you can perform this surgery very successfully. I have a good clinical record of that, and I have published paper about that, and I teach other people to do that. So it is a doable thing, but it is a difficult field.
Yep.
So
another challenging topic. Yep.
Okay,
we have 5 minutes left. So how about this? We say goodbye by just each of us go around and just talk about whatever it is that they want to talk about. The last final thoughts, message, insights before we say goodbye to everybody. So ladies first, Dr. Grunch, do you want to go first?
Sure. Yeah. Just thank everybody for joining. I know there was a lot of questions. I try to answer some in the chat boxes there, but just thanks to everybody for coming. I know a lot of patients are out there with questions. There's some students and people in our field out there too, but for patients specifically, finding a surgeon that listens to you is so important, and that really focuses on your pathology, where your pain is, and really invest their time into explaining things goes a long way. I think that you should always feel comfortable with the surgeon that you're seeing. And if anyone ever makes you feel rushed or you feel not confident, then always seek a second opinion. Spine is such as you've seen by just some of our answers, it's a very challenging field, and there may be 6 different ways to fix one problem. And you may see different surgeons. So I think, understanding what you're getting yourself into before you sign that consent form is so important, because spine surgery can be life-changing, good or bad, for a lot of people. And unfortunately, in our field, we see patients that have bad outcomes, and unfortunately, we see some with fantastic outcomes. So we want everybody to have a successful surgery, and just make sure you feel comfortable. That's my recommendation.
Well, thank you, Betsy. You took all my talking points.
Sorry.
I don't know what to say.
You paid
now.
me $5 for that.
Except that research your surgeon. If your surgeon is a black box, that's already a little red flag. Know your surgeon. Be comfortable with your surgeon. And part of our protocol, our surgeon have to strongly recommend to the patient to get second opinion. And if a surgeon is uncomfortable with you getting a second opinion, that's even more reason to get a second opinion.
I agree.
And educate yourself. It's 2023. It's not 1960s. There's lots of information out there. And this is one of the TikTok I think I made. I actually copied somebody else. If you go there and you're confused more after you meet with your surgeon than you were before, then you need to talk to somebody else. I think that's what part of our job is, to make you understand what you're going through, what problem you have in terms, in language that makes it for you understandable. So if they ever make you, if anybody, not only medicine, if you go to your banker or tax expert, and after that you're more confused, you understand less, you need to talk to somebody else. And there are information out there. Research your surgeon.
Darn it, you said everything I was going to say now too.
Yeah, I mean, I would also add to that too, that it's so easy to go on Google and look at the reviews, but there are fake, like, you can hire companies to give you 5-star reviews. So if you go on someone's website and see 1,500 5-star reviews, like that can't be real life. Like, I've been in practice for 10 years. I've never hired a company to do anything for me. And I think I have like 30 or 45 Google reviews. I can't get anybody to, the patients that are doing well, they don't want to go online and do it. So just be wary of those reviews online, and ask. I have a patient advocacy program in my practice. Like, if a patient wants X, Y, and Z surgery, I said, listen, talk to my patient that's had the same procedure, and talk to them and see, answer your questions you have. So just those are other things. I think educating yourself is so important.
Yes, absolutely. There are more than just reviews. It's your surgeon.
We didn't talk about this ahead of time, but we're all three on the same page. the take-home message is it's a new time now where people have access to a lot more information, and there's a group of physicians that enjoy getting the message out. And by having this kind of video format, this digital strategy now, it's completely different than it was 5-10 years ago. And especially the people that are on this webinar, you're the ones that are hungry for information. You're the people that other people look toward for medical advice probably. And so we thank everyone that's actually live here, and we thank all the people that are looking at all the videos. And you probably know what's real and what's not real. And I encourage you all to share your knowledge with, like what I do with my friends and family. They all come to me for everything. And I disseminate information. My daughter's the same way. And I encourage all of you to kind of encourage everybody to really get out there and learn about what their problem is, because there's a lot of really good information out there.
And ask other healthcare professionals in your community. I mean, I know when I'm looking at a surgeon, I ask the people that work in the operating room because they know who's good.
That is crucial.
And physical therapists too, and the nurses.
Therapists. People that see the outcomes of the surgery, physical therapists, home health companies, you know, nurses, people that work in the operating room. Doesn't have to be physicians. Those are going to be the people that are very knowledgeable in seeing those patients that have certain surgeries by that surgeon. And that may not always be the easiest to come by, but definitely just kind of do your due diligence. So
as well, the nurses in the floor who take care of those patients after the surgery. That is very wise advice.
All right, we're 1 minute over, but thank you both for joining me on this. And thanks to all the participants. We hope this was helpful, and share any other comments for future ideas on more webinars. So God bless and Happy New Year to everyone.
Thank you very much. It was very much fun.
Happy New Year.
Happy New Year.